Nazal Zero and in the memory of late Dr. K.K. Agarwal sir. Viewers, you will agree with me that weight control is an important aspect of diabetes treatment and can improve glycemic control and cardiovascular risk factors per se. The term diabesity is used to define the pathogenic relationship between diabetes and obesity. So before I hand over the platform to Dr. Kalra sir to take us on today's module, which is weight optimization and diabetes and its important aspects, let me have the opportunity of announcing the names of those doctors who have answered the quiz questions correctly from the last episode. And the names are Dr. Satish Kumar Jain from Karnataka, Dr. D.G. Parmar from Maharashtra, Dr. Dharmendra Tandon, Dr. Kulbhushan Tandon from Maharashtra. Dear viewers, next Sunday, that is 14th August, on the occasion of World Pre-Diabetes Day, we have a very big event coming up, which is will be live at 9 p.m. same time on the same platform as well. Dear viewers, Dr. Julio Rosenstock, who is the director of Dallas Diabetes Research Center, USA, and who is also pioneer and international KOL whose opinions matter in the fact of novel diabetes research, will address Indian doctors on newer drugs for diabetes. And this session will be moderated by our very own Dr. Sanjay Kalra sir, who is the president-elect of South Asian Federation of Endocrine Societies. So if you have not enrolled for this webinar, please do enroll for the same. Please do pass on this message to all of your peers and colleagues who love to keep an update in diabetes. And with this, let me hand the platform to Dr. Kalra sir. So over to you.
Thank you, Rahul, and warm greetings to everybody, everyone who has logged in on this Sunday evening. Today, we'll be talking about an important aspect of diabetes. We'll be talking about an important aspect of diabetes management exactly, and that is weight optimization. When we look at the guidelines from ACE, that is American Association of Clinical Endocrinologists, we see that their main philosophy is reducing weight. In India, we have different types of patients. Some of our patients are overweight, others are obese, some may be morbidly obese. But we do have patients who are normal weight and underweight as well. That is why the correct word for us, the correct phrase for us should be weight optimization in diabetes. Weight optimization means that we should try to optimize the weight or the barometabolic health, baro, B-A-R-O, barometabolic health, while ensuring good glucose control as well. This is important because just like hyperglycemia is associated with cardiovascular outcomes and hypoglycemia is associated with cardiovascular outcomes, bad cardiovascular outcomes. Similarly, excess of weight and too little weight both are associated with adverse outcomes. Unfortunately, however, with conventional therapy, with conventional diabetes therapy, weight gain usually occurs. And when you are managing diabetes, you have to manage weight as well. This is important. But supposing we correct diabetes, what happens? The urinary frequency goes down, less urine is passed, glucosuria goes down, less glucose is excreted through the urine. So all these calories get saved. When you manage diabetes, the entire nervous system improves, the autonomic nervous system improves, the gut health also improves, and you get better absorption of food from the gut. So better absorption of food and also reduced excretion of glucose, these can lead to weight gain. Not only that, there are some anti-diabetic drugs which can also increase weight. So if we go to the drugs one by one, sulfonylurea use is linked with weight gain. Metformin reduces weight as compared to sulfonylureas, but alone it is not a weight reducing drug. It will not reduce weight. However, it will not allow weight gain also. Thiazolidine that is pioglitazone, is associated with weight gain. If you combine sulfonylurea with metformin, you will have less weight gain. If you combine pioglitazone with metformin, the weight gain will continue. The pioglitazone weight gain occurs because of its actions on the PPR gamma receptor, and there is fluid retention. Metformin will not stop that. So conventionally, sulfonylureas will increase weight gain, pioglitazone will increase weight gain, metformin will not increase weight. Metformin plus SU, weight gain will be less. Metformin plus pio, weight gain will continue. If we give alpha glucose inhibitors like acarbose or voglibose, that has a insignificant effect on weight. Weight might come down slightly, but it has been seen that voglibose co-administration can reduce the weight gain associated with pioglitazone. So this is for conventional molecules. For the newer molecules, DPP4 inhibitors are weight neutral. GLP-1RA reduce weight, that is semaglutide, liraglutide, dulaglutide, the ones that are available in India. Semaglutide and liraglutide are used off-label as anti-obesity drugs in India, and in foreign countries they are approved also for weight loss. SGLT2 inhibitors like empagliflozin, dapagliflozin, canagliflozin, they help in weight loss. All of them will cause equal weight loss, but if you want the maximum weight loss with an SGLT2 inhibitor, then the drug of choice is canagliflozin 300 milligram. The insulins are also associated with weight gain. Out of all the insulins, it is insulin detemir. The trade name is Levemir, which is associated with minimum weight gain. Now, there is something known as the KG-A1C paradox. KG-A1C paradox says that as you try to bring the HbA1c down, you end up increasing the kg or the body weight. So while you are bringing down the HbA1c to reduce cardiovascular outcomes, you end up increasing the body weight or the kg, and you end up worsening cardiovascular outcomes. So this paradox is something that earlier we had not been able to break or solve. But now with the development of GLP-1RAs and SGLT2 inhibitors, we are able to resolve the KG-A1C paradox. It is important to do this because if you don't, then weight gain will mitigate the benefits achieved by glucose control. It is important to use metformin, but metformin has its own side effects and contraindications. And it does not make sense to use 3 grams or 2.5 grams of metformin for glucose control. You will not get much additive glucose control if you increase the dose beyond 1.5 gram. However, if you increase the dose beyond 1.5 gram, certainly you will get more side effects and intolerance to metformin. So metformin has to stay at the most 1.5 grams. We also cannot use too much of insulin, because if you use too much of insulin, that can cause hypoglycemia, which can increase snacking and which can cause weight gain. So therefore, to break the KG-A1C paradox, our two drugs of choice are GLP-1RA and SGLT2 inhibitors. However, there is a lot that can be done by the physician apart from giving drugs only. We should reinforce diet and physical activity as effective methods of both glucose and weight control. Tell your patient that a healthy diet and regular physical activity will improve muscle mass, muscle sensitivity to insulin, and this will help keep you in the healthy zone for both glucose and weight. Also tell your patients that we will change doses. Now, I do write a lot of pioglitazone, but I tell my patients, in case you feel that your belt is tightening, your trousers are becoming tight, you feel that you have to go to the tailor to buy a new blouse or a new shirt, please don't do that. Come back to us. So you do it in a happy way. So, madam, if your clothes fit you, continue with this medication. In case you feel you have to buy new clothes because the size is changing, please do not spend money on clothes. Come back to us. We will change the medication. If you tell this to your patient, very, very rarely will you have to refer to a specialist. You will be able to manage the weight yourself. You can also tell your patient to undergo regular physical activity, exercise different muscle groups, keep on changing exercise regularly so that all the different muscles of the body benefit. If you're focusing on weight, it makes sense to measure as well. So measure waist circumference, hip circumference, weight. You can also measure neck circumference if you want, and do look for edema. If you see edema, It means the patient is getting excessive dose of pioglitazone or perhaps insulin as well. And in case you see edema or weight gain, do review not only the anti-diabetic but also other medications. It is possible patient may be on amlodipine that can cause edema. A combination of DPP-4 inhibitor and ACE inhibitor can cause edema because you are inhibiting DPP-4, you are inhibiting ACE. When both of these are inhibited, there is nothing left to break down substance P. Substance P is a peptide which causes edema. So if you are giving DPP-4 inhibitor and ACE inhibitor together, it is possible substance P may rise and that can cause edema. Maybe patient is getting corticosteroids. That can cause edema. Maybe patient is eating too much salt. Focus on that. Patient might be having salt sensitivity, premenstrual syndrome. These are all things that should come to our mind. So how do we treat a patient if there is excessive weight gain or there is edema? First, discontinue pioglitazone or replace pioglitazone with another drug. Second, reduce the dose of insulin, especially rapid-acting insulin. Third, in basal insulin, all are safe, but detemir will be the safest for someone who is getting excessive weight gain. Fourth, increase the dose of metformin to maximally tolerated levels. Uh, Above 1.5 gram, there will be not much of value in terms of glucose control, but you will have value in terms of appetite suppression and maybe weight loss. And of course, the drugs of choice will be GLP-1RA like injectable liraglutide or oral semaglutide, and also SGLT2 inhibitors like empagliflozin, canagliflozin, and dapagliflozin. With GLP-1RA, the main tolerance factor to look for is GI tolerance. It will be temporary, it will not be severe, and it will resolve on its own. It will be self-limiting and mild. With SGLT2 inhibitor, the main issue is genital infections like belanoposthitis or pruritus vulvae, and also a risk of euglycemic ketosis. We use many terms in diabetes. One of the terms we use is glucocentric choice of therapy or cardiocentric. But another method we have is Varo-centric, Varo or Baro-centric. So here we are talking about weight optimization. So far we have talked of overweight and obese patients. In overweight obese patients, you need a high focus on lifestyle modification. You can use GLP-1RA, SGLT2 inhibitor, and a basal insulin plus GLP-1RA. If your patient, however, is underweight, then the drugs to prefer are pioglitazone, intensive insulin regimen, and if you're using premixed, you use more of high mix preparations so that the patient feels more hungry and eats more food. So a 50-50 preparation will be considered better. Metformin can be used, but used with caution and used in low dose in underweight patients. Metformin is a calorie restriction mimetic. And if your patient is already calorie restricted, it doesn't make sense to mimic the calorie restriction further. For normal weight patients, any drug you can use. So sulfonylurea plus metformin or DPP-4 inhibitor plus metformin or triple oral drugs, any insulin that is required clinically that can be used. Today, we are speaking of weight optimization, and weight optimization will not be possible until you explain diet to your patient. So today I thought, let me explain the diet the way I do in my OPD without the help of a dietitian in 3 minutes. So let us count ourselves and let us see if I am able to finish my diet in 3 minutes. We call this the 3 by 3 by 3 diet. Anyone who has a stopwatch, if you can time us, please. So, madam, 3 is a very important number. 3 is a very important number. Divide your meal into 3 major and 3 minor meals. Breakfast, lunch, dinner, and 3 small snacks. Each plate should be divided into 3. 1/3 cereals and starchy vegetables. In Hindi, it sounds quite alliterative. 1/3 aloo, arbi, anaj, potato, cocoyam, and cereals. The next 1/3 should be colored vegetables, colored fruits, colored salad, rangdar sabji, rangdar phal, rangdar salad. And the third part of the plate should be protein rich. Dal, dahi or doodh, or deh, that is flesh in Hindi. So dal or lentils, curd or milk or dairy products, and non-vegetarian food and eggs. Follow an order of eating food. So first you drink salad, then you first you drink water or soup, then you eat salad, then you take the protein rich food, and in the end you take the carbohydrate rich food. So this is the 3 by 3 by 3 diet. Three major and three minor meals, one third starch and cereal, one third colored vegetable salads, fruits, one third dairy products, dal, and non-veg food. The food sequencing: first, soup and salad; second, protein rich food; third and last, carbohydrate rich food. That is the order we should take. Sometimes we can do a 2-minute diet as well. So this is something that I also use in the OPD. You can customize it, but do note that this is a slightly protein deficient diet. So here in 2 minutes now, let us time ourselves. One helping of cereal is equal to 30 grams of uncooked food. 30 grams of uncooked wheat or uncooked rice is equal to 90 grams of cooked wheat or cooked rice. So you should have this helping of cereal in your mind, 30 grams, and we should allow, let us see what we should allow in terms of the number of helpings per day. One helping of salad is considered equal to roughly 150 or 200 grams, one big bowl of raw vegetable. One helping of fruit is also equal to 200 grams, roughly the size of a big bowl or maybe a cricket or tennis ball. Similarly, one helping of dairy products is 200 ml of milk or yogurt or cheese. 200 ml milk would be the average glass that you get in an Indian kitchen. And one helping of lentils or dal is also equal to 30 grams uncooked or 90 grams cooked food. So you just have to remember two numbers now: 200 gram of vegetable, 200 gram of ripe fruit, 200 gram of milk. That's one number, 200. The other number we have to remember is 30 gram of uncooked dal or wheat flour or rice, which is equal to 90 gram of cooked dal or wheat flour or rice. Now, how do you do it in 2 minutes? Check the weight of the patient, divide by 10. So if I'm weighing 100 kg, that's my weight. Weight divided by 10 is equal to 10. So I will eat 10 chapatis or 10 plates of rice in a day. I can do that as 3 major meals. I will divide. 10 is also equal to the number of side dishes that I will take. So what are the side dishes? That will be an equal division between salad, fruit, dairy product, and dal or non-veg. So that means 10 divided by, let us say, 2 is equal to 5. So 10 divided by 5 is equal to 2. So I will take 2 plates of salad, 2 plates of fruit, 2 plates of dairy product, 2 plates of dal, and 2 plates of non-veg. Now this suddenly seems huge, but see, it is for 100 kg patient. Assuming that 100 kg is the normal weight for that patient, assuming that my height is also maybe 6 feet 6 inches, which it is not. But weight divided by 10 is equal to number of chapatis. Weight divided by 10 is equal to number of side dishes. Side dishes will be divided into 5 equal parts: vegetable, fruit, milk, dal, and non-veg. If the patient is underweight, add 10% to this. If the patient is overweight, subtract 10%. If the patient is obese, subtract 20%. If the patient is antenatal or lactating, add 10%. If the patient is a child or adolescent, add 20%. Now that was for 100 kg. Let us do for 50 kg patient now. 50 divided by 10 is equal to 5. So total 5 chapatis per day, or maybe 10 idlis per day. Total, remember that number is equal to 30 grams of uncooked rice or uncooked wheat. So 5 is the number of chapatis or idlis. 5 is the number of side dishes. So I will take maybe one helping of salad, one helping of fruit, one of milk, one dal, and one non-veg in the entire day. Another N is equal to the grams of cooking fat or oil to be consumed per day. So we should try to minimize that. Weight divided by 10 is equal to the grams of ghee or oil that should be included in the diet. So these are some ways that I use in my OPD, the 333 pattern and the weight divided by 10 pattern. And I am able to explain in 2-3 minutes. But a question we have for everyone, what is the first line drug for patients with type 2 diabetes and obesity? Is it acarbose, metformin, sulfonylurea, or insulin? So this is our question for today. The first line drug for patients living with type 2 diabetes and obesity is acarbose, metformin, sulfonylurea, insulin. With this, let's take the questions that we have for today. And lots of questions coming in. So from Dr. DG Parmar, good evening, sir. Is hyperuricemia above 7 a primary risk factor? Yes, it is. If yes, does it require uricosuric agents? No, it is a CV risk factor, but asymptomatic hyperuricemia we should not treat because there is no data to show that it helps. However, if your patient has painful gout, then certainly we must give regular uricosuric agents. And Dr. Parmar mentions that febuxostat is preferred as compared to allopurinol. If patient has acute gout, febuxostat will not correct the acute pain. Neither will allopurinol correct. They will act slowly. For acute pain relief, you will have to give a pain reliever, an NSAID or maybe an opioid analgesic. From Dr. Vinay Desai, clinical challenge. Patient is on premixed insulin. There is hypo before breakfast. Okay. So then we will tell the patient if there is hypo before breakfast. Number one, you have to reduce the nighttime dose, but that you can do only in the night. Reduce by 10 or 20%. Secondly, to correct the hypo, first you take some sweet or fruit. Then you have breakfast. You can take the premixed insulin after breakfast. So Dr. Vinay Desai rightly says, nighttime insulin must be reduced. Yes, sir, that is correct. And secondly, he rightly says we should give the insulin after breakfast on that day. Yes, sir, we should give after breakfast. It will be safe. Dr. Gangadhar Rath says, can we give telmisartan twice a day? Yes, sir, many times we are giving twice a day. So it helps reduce the nocturnal BP as well. And feel free, feel comfortable to give them twice a day if you want. There will be no harm to the patient. And each patient, you are the best judge to decide whether you want to give in the morning, at night, or twice a day. You can give. Dr. Vinay Desai says, what food items have complex carbohydrate? So that will be, sir, what we were just speaking, that 1/3 food. That will be chapati, rice, and starchy foods like potato, cocoyam. But the method of cooking is important. If you take atta, that is wheat flour, chilke wala, with the husk, brown color, that will have complex carbohydrate. If you take milled atta, which is MILLED, milled atta, yeah, white atta, that will not have fiber, it will not have complex carbohydrate. And even less than that, if you take suji or maida, suji, the English is semolina, and maida, I think it is refined wheat flour, they will have no fiber, there will be no complex carbohydrate. Similarly for rice, if you dehusk the rice, the complex carbohydrate comes down. For chane ka atta, that is chane ki dal ka atta, if you take chane ka atta, chilka samet with the husk, that has got complex carbohydrate. But if you convert it into besan, besan is chane ka atta without the fiber, without the husk, without the chilka, that will not have complex carbs. And besan actually increases sugar a lot, while chane ka atta will reduce. Even in the dals, you can have whole dal like rajma, kala chana, safed chana. They will have more complex carbs. But if you have dhuli hui dal, like moongi ki dal, dhuli hui dal, washed dal, which is broken into two and which is dehusked, that will have less carbs. More questions coming up. And Dr. Suresh Pawar says, 8-year-old girl child, type 1 diabetes on Novorapid 4 units 3 times a day, Lantus at night. Evening glucose shoots up. Most probably, sir, she is taking some snack in the evening, or Lantus is not working for 24 hours. That is why when you give Lantus at bedtime, it begins working, but around 20 hours after the Lantus, it stops working. So options are best would be to change Lantus at night to Glargine U300, the trade name is Toujeo, or Tresiba. Same number of units will work with Tresiba, 10, and with the Toujeo you may have to go up to 12. Tell the patient that glucose control will come after 5 to 7 days because it will take that much time for the drug to begin acting. Second option is, if patient is willing, we can give Lantus twice a day. So we can give maybe 6 units twice a day, but that will make it 5 injections. Do note that for U100 glargine like Lantus, if it is a low dose like 10, 12, 14 units, the duration of action is about 18 to 20 hours. As the dose goes up, as the dose per kg body weight increases, the duration of action also increases. The pharmacokinetic profile changes. So first option was changed to Toujeo or Tresiba. To Tresiba, same dose, Toujeo increased by 10%, 20%. Second option is make Lantus 2 times a day. Third option is look at the evening snack. See what the patient is taking. Patient might be taking Haldiram namkeen or anything else with a lot of calories, so try to change that. And you can also give Acarbose, 25 or 50 milligram with the evening snack. Now, Acarbose is a drug that is approved for use in diabetes, in type 2 diabetes, in type 1 diabetes also in India it is approved, in pre-diabetes, and it can also be used in gestational diabetes as a last resort. And beauty is it is used in reactive hypoglycemia as well. So in reactive hypoglycemia, what happens is glucose goes down and then it goes up. So Acarbose will smoothen that up and down. Dr. Rakesh Bhatia asks about the code for accessing archived sessions, and the answer has already come. It is, sir, it is Enerzal Blitz, ENERZALBLITZ. And please do go through them and let us know if there is any shortcoming. We will try to address them. Lots of more questions. Kausar Pathan ji asks how to gain weight. Pathan sahab, mujhse pucho. I am struggling to lose weight. But we can always take a separate session on this. From type 2 diabetes point of view, pioglitazone would be a good drug. Insulin would be a good drug to gain weight, especially intensive insulin therapy. From Dr. Humanity, can we use pioglitazone in addition to sitagliptin, SGLT2 inhibitor, and metformin for weight loss? So pioglitazone will actually increase weight. However, you can give it with these drugs for glucose control. Nitin Narula ji complaining of weakness and lethargy and body aches. If this is a persistent problem, Nitin, then we have to find another reason apart from sugar and BP. The BP medication like atenolol, beta blocker might be causing body aches, but do consult a doctor and a rheumatologist and they will find the reason for you. The treatment for smoking. Now, smoking addiction is very difficult to handle, actually very difficult to handle. And this question is from Dr. Gauri Shankar. You can give the nicotine gum. You can prescribe topiramate, 25 milligram or 50 milligram once a day, which is a safe drug that will reduce craving for smoking. Amongst the glucose lowering therapies, giving liraglutide or semaglutide will actually reduce the hunger for alcohol or for smoking. So you can add a GLP-1 RA like liraglutide or semaglutide. Nicotine gums and patches are not so useful, but they do help satisfy the patient. Even after multiple attempts, patient is not able to stop smoking because it is difficult. It is actually difficult. So do consider adding oral semaglutide, 3 milligram once a day, 30 to 60 minutes before breakfast with maximum half a glass of water. Only challenge is the oral semaglutide will cost 300 rupees. You cannot give along with DPP-4 inhibitor. You can give with any other therapy. Another case is a 70-year-old gentleman weighing 90 kg, retired forest officer on triple dose metformin, glimepiride, voglibose, on dual blood pressure lowering therapy, telmisartan, amlodipine, and also on atorvastatin. So very good therapy that has been given, but still patient's HbA1c is 11.5. Now he is diabetic for 10 years. So ideally we should be adding insulin. If patient doesn't agree, you can stop the voglibose. You can add DPP-4 inhibitor and SGLT2 inhibitor. So stop voglibose. It will not act in such a patient. Add maybe dapagliflozin 10 milligram or empagliflozin 10 milligram once a day. add sitagliptin or vildagliptin 50 milligram twice a day or linagliptin 5 milligram at night, and motivate the patient to take insulin. Also focus on diet and exercise. See if patient is eating too much of ghee or oil. That might be the culprit. Teach the patient something called Pareto's law. Now, Pareto was an economist who said that 80% of all of India's money lies in hands of 20% people. 80% of all the calories, undesirable calories that we eat come from 20% of our food. So maybe patient is eating ghee on the chapati, maybe some fried food, some fried snacks, which are causing the hyperglycemia. Exercises for obese middle-aged 45-year-old men who have diabetes, tell them to begin exercising. Anything is better than nothing. First, begin with flexibility and balance. Once that has been achieved, then you move on to aerobic exercise and then to resistance. Roughly, if they are going to spend 7 hours on exercise, so 5 hours should be aerobics, 2 hours resistance. Minimum 3.5 hours per week is required. Knee pain in a 45-year-old person will be because of arthritis usually, and it is, you have to tell the patient to lose weight. Obesity, what I do in OPD, I tell them to drink haldi wala doodh, which is turmeric milk. That helps a lot. We tell them to reduce weight by exercising, and we tell them that maybe we cannot help the knee too much, but we can help your muscles. So we can help strengthen your muscles so that they take more of the load. So you teach them quadriceps building exercises. And left hip to foot pain, this is very common in people with diabetes. It can be neuropathy, it can be radiculopathy. How to proceed? First of all, good glucose control. Secondly, physiotherapy, ask them to exercise. Third is, you will, if the patient is thin, lean, very old, maybe gabapentin 100 milligram, we will start with. If patient is obese, relatively younger, has severe pain, then pregabalin 75 milligram. So as monotherapy, gabapentin 100 for thin people, old people, pregabalin 75 or gabapentin 300 for the relatively younger ones. One drug which I use very frequently is a combination of duloxetine 20 and pregabalin 50. This helps a lot. My most common prescriptions actually are gabapentin 100 for thin people, old people, and pregabalin 20 plus duloxetine, pregabalin 50 plus duloxetine 20 for other people. For those who do not respond, I up titrate, I go to pregabalin 75 plus nortriptyline 10. So these are my common prescriptions. For quick pain relief, you will have to give tramadol. So tramadol plus paracetamol combination. If you are suspecting radiculopathy, simplest test would be X-ray lumbar spine, AP lateral, and if possible, MRI. Depression, initial drug to start. First of all, smile, tell the patient to be happy. I usually start escitalopram, 10 milligram, plus clonazepam, 0.5, 0.25 milligram. FDCs are available. So for depression, my commonest prescription is escitalopram and clonazepam, which is anxiolytic. For sleep, I have begun using lemborexant, 5 milligram, sometimes 10 milligram, but mostly 5. Lemborexant is a non-benzodiazepine drug, which also helps improve glucose control in the morning. And next question that Dr. Gauri Shankar asks is difficulty in sleep. So lemborexant would be the drug of choice. Another good drug is zolpidem. You tell them that these are both non-benzodiazepine, they are non-addictive. So lemborexant, the trade name is Dayvigo. Zolpidem, the trade name is Zolfresh. Both are available as 5 and 10 milligrams. Start with 5 milligram first. Statins are weight neutral. These questions come from Dr. Humanity. I love the name, Love Humanity. Steroid of short course of steroids in diabetic musculoskeletal pain, we should avoid, sir, because it will worsen the patient in long run. If it is musculoskeletal pain, you use pregabalin duloxetine combination plus tramadol and paracetamol for short period of time. Encourage the patient to exercise and gain physical fitness. Deflazacort is the same as the others. Do not use in diabetes. Deflazacort is marketed as glucose neutral drug, but it is not. It will increase glucose levels. Chronic insomnia, again, lemborexant and zolpidem, these would be the drug of choice. 10 milligram we will have to start. in case patient is not responding to benzodiazepines. You can also try mind-body medicine. Tell the patient to learn cognitive behavioral therapy, drink a glass of hot glass of milk at night, along with maybe cashew nuts. Cashew nuts are good source of serotonin. Another thing is that most of the serotonin, Dr. Anshul Singhai from Bhilai is there, and he will also tell us that most of the serotonin in the body is made by the microbes in the gut, by the gut microbial microflora in the gut. So, apart from thinking about antidepressants, you can also think about your gut and how to keep it happy. Best way of keeping your gut happy is to take one bowl of curd in the morning and in the evening. That has got a lot of probiotics. You can also try. You can try probiotic preparations. Like one example is Good Right, which is of course good for gut health and might also help in metabolic health. Glaucoma does need to be ruled out, yes, with duloxetine. And in general, when we ask for eye checkup, it is not only the fundus, we should also ask for general eye checkup. Anti-anxiety, you can use any benzodiazepine like clonazepam or atizolam. I use both of them in practice. And thank you, everybody, Dr. Gauri Shankar and Dr. Anshul. Also, love humanity. I love your name for taking today's discussion to such a high level. We continue with other questions, and Dr. Namrata Pashine says metformin plus Voglibos in the afternoon. Okay, let me start the question all over again. The patient is obese since childhood and has developed asthma as a response to metformin, which is quite rare. So maybe first of all, we try different formulations, different companies. You can try metformin 500 milligram or 250 milligram, immediate release. Try that first and see what happens. And metformin was taken earlier, the results were very good, but now is not, the patient is not able to take. So do try simple metformin, non-sustained release, before you are sure that it's causing asthma. You can take cetirizine along with that. Teneligliptin, maybe we should avoid the gliptins. So anybody with a tendency towards allergy, especially skin allergy, avoid gliptins and prefer SGLT2 inhibitor. Another question is coming from Dr. Ashwini. Ketonuria, yes, is absolute contraindication to SGLT2 inhibitor because that might precipitate ketoacidosis and then we will get in trouble. So we should avoid it. It is absolute contraindication. Ask the patient to drink more water at least. Dr. Vilas shares another case of who is on Novomix 20 units BD and also Geminarem BD, but still not getting controlled. And now fasting is 160 to 210. So, Dr. Vilas, we should take patient into confidence and say that allow me to give you 4 injections per day for short period of time. Novomix is like khichdi. It is a mixture of fast acting and long acting. Let me change the khichdi into dal and chawal separately. Let me give you a biryani. Let us give you 4 injections per day, 3 short acting and 1 long acting. Now, since the fasting glucose is very high, maybe patient is already on 40 units. Let us change to 50, and we will give 10 units TDS of rapid acting, 20 units of long acting at night. Also, we will stop the sulfonylurea, Geminor. We will continue metformin 1 gram BD. We will also add, sitagliptin or vildagliptin 50 BD. We will add SGLT2 inhibitor if there is no urinary tract infection. We can also talk to the patient about oral semaglutide, but that is expensive. Liraglutide injection, that is also slightly expensive. But already we are telling patient to take 4 injections, so I will not think of speaking to patient about 5th injection right now. So this is pharmacological optimization. Secondly, we will do lifestyle optimization, diet and exercise and sleep. Sometimes in such patients, if fasting is very high, a small tablet of clonazepam, 0.25 milligram at night, or lemborexant, 5 milligram at night, actually does the trick. Patient sleeps better and gets better fasting glucose. And Dr. Ashwini Kumar actually points out that bromocriptine had been used earlier in the morning, not for sleep, but for glucose control. Bromocriptine is given at night to manage hyperprolactinemia. Timed release bromocriptine, timed release QR bromocriptine is given in the morning, first thing on getting up, to manage diabetes. But now bromocriptine has been replaced by other drugs like cabergoline for hyperprolactinemia and by other drugs for glucose because the tolerability was not very good. But the same logic for giving bromocriptine, it handles dopaminergic release from the brain. That same logic is what we use when we are giving a lemborexant or we are giving clonazepam at night to some of our patients with diabetes. But Dr. Vilas, do let us know next week or after 2 weeks how your patient is doing. Request the patient to go on basal bolus for short period of time. Add a sleep-inducing drug if required. Stop Geminor. Continue metformin, same dose, and add SGLT2 inhibitor. Add either DPP4 inhibitor or oral sema. Optimize diet and exercise as well, and let us see what happens. Rule out any infection also. Any kind of infection can worsen glucose control. With vitamin D, Dr. Anshul says calcium should be supplemented or just vitamin D in person with normal PTH. So vitamin D for most people, calcium for all postmenopausal women and those with documented calcium deficiency. Only for those who are postmenopausal and those with documented calcium deficiency or sarcopenia. And Dr. Humanity says that zolpidem is safe for cardiac patients. Lemborexant is also safe for cardiac patients. That is right. And thank you very much. Do continue being with us, and we are all inspired by the fact that you attend these programs. Okay, one question from Dr. Singhai is, some physicians give 50% basal with 50% divided into rapid acting. This is correct, especially for type 1 diabetics. Others give basal 25 and the rest 25 is prandial. This will be true for gestational diabetes. In general, as a starting point, the first one is better. Total insulin divided into two, 50% to go as basal and 50% to go as rapid acting divided into three. So that will be something like 16% each time. Especially in children, especially in type 1 diabetes, 50-50 formula is better. But in some people, like in gestational diabetes, the 25-25-25 is better. Follow the 50-51 and then you titrate according to requirement. What happens now is that we have very good safe basal insulins. They are ultra long acting, but the risk of hypoglycemia is minimal, so we don't worry too much. I'd like to thank everybody for all the questions that have come. Today's questions have one good thing. This is speaking to everybody. मतलब मुझे बहुत अच्छा लगता है. What I see is that the quality of discourse and discussion is going up, and that keeps me on my toes. I have to keep on reading also, but it is fun, and that tells us that we are headed in the right direction. One last question, let us take from Dr. Saurav Chaudhary. Fasting 113, PP 195 on glimepiride and metformin. This is not excellent, but it is very good. So we are happy. Now, is there any need to start DAPA or VILDA or both? So for glucose control, we are not too bothered. So we don't need to start VILDA. But dapagliflozin, we can start. It will help in improving long-term CV outcomes, long-term renal outcomes. So to this patient, Saurabh, what we will tell is your glucose is wonderful. Thank you very much. You are doing a great job. Thank you. And we will repeat this thank you. We would want you to take an insurance also so that later on, 10, 20, 30, 40 years from now, you don't suffer from heart disease, kidney disease. Allow me to add one drug. Don't think of it, allow me to add one tablet. Don't think of it as a drug. Just think of it as an insurance for yourself. So let me add dapagliflozin. I would also give this patient the option of taking acarbose. What I would say is that let me add another tablet for you. You don't have to take every day. But this speaking in Hindi, जब भी कभी कोई तीज त्योहार हो, whenever there is any festival or whenever you go to a party and you feel that you are sort of going to eat unwanted things, too much of sugar, too much of oil, then maybe you can take one tablet of acarbose. Acarbose will actually help if there is a high carbohydrate load, and you can take it on SOS basis. It will not cause hypoglycemia. For the oil, the actual treatment is orlistat. But if patient take it, they will not take it SOS, and whether it works or not, I don't know. But certainly it will cause side effect. If you take orlistat with a high oil or high fat diet, then you will get diarrhea, steatorrhea, and patient will be very unhappy with you. But for this patient, Saurav, ek to very well done. You're doing a great job. Do add dapagliflozin for long-term CV outcome, and give the patient a choice of taking acarbose every now and then if required. There is one more question, and honestly, Dr. Humanity, I have forgotten. That is, what would be the next session topic? So, Rahul, if Rahul is online, he can tell us. Otherwise, what I do remember is that in August, we are going to be discussing diabetes, and from September, we'll be talking about iron metabolism. And we'll have a ten webinar series on iron talks, which I'm also looking forward to eagerly,
So
because that will.
14th is our tent pole event with Dr. Rosentek. So that's the
Oh,
big
yes.
one.
Thank you. So, yeah, Dr. Humanity, this is a great program. Dr. Rosenstock will be speaking about the newer drugs and
Yes.
when to prescribe them. He will also talk about concerns, caveats, and checkpoints. What are the things we should be watchful for? What are our checkpoints? What should we test? And what are the caveats, the do's and don'ts of using these newer drugs? So I think the entire pharmacotherapy of diabetes will be covered in that. So thank you, Mr. Basu, for reminding us.
Okay.
Thank you. Good book on thyroid, Anshul. API textbook is not bad. I am the editor of the endocrinology section. Mm, and there is one nice simple book for patients written in Telugu, but there is an English version also. This is from our friend Dr. Rama Mohan, who works in Nellore in Andhra. So maybe Team FDC can source that for you.
Okay.
So Dr. Rama Mohan is a young and dynamic endocrinologist from Nellore, Andhra Pradesh. His book on thyroid it's a very sensible and simple book to read. So thanks, Anshul, for raising this point as well. And I'd like to thank everybody for having been with us today. There are two more questions. Oh, okay. Newer drugs and diabetes, Rahul has helped us answer. So thank you. I'd like to thank everybody for being with us today. And Mr. Basu, over to you.
Sir, we thank you because you have not only extended your question answer sessions and from our behalf and being you as a moderator on 14th of August, you have reminded all our viewers that do not forget to watch on 14th August 9 p.m. show with Dr. Sanjay Kalra because that's one of in a quarter period of time. So with this, I thank sincerely Dr. Sanjay Kalla for extending his support for Diabetes Essential. Look forward to meet him on 14th of August. Thank you very much, sir. Good night. Jai Hind. Har Ghar Tiranga
Exactly.
Abhiyan.
Oh, yes. And our boys and girls are doing so well in
Yeah,
Birmingham in the Commonwealth. बहुत खुशी होती है. It's so nice. So, Jai Hind and do well.
right, sir.